substitute. And as of last night, Hailey was trying to tell me I wasn't the one who was actually going to be up here, so I don't have a PowerPoint. But
Thankfully.
but I'm glad that Hailey and Samaya showed really all the data. I'm a data person, but I don't really want to speak so much about the data. I'm happy that Hailey pointed out that the synergies between TASP and TB control, and there are many. But what the new guidelines recommend, well, they recommend ART for all TB patients regardless of CD4 cell count. And we know that people with HIV, from the moment they are infected, have a dramatically increased risk of TB, of active TB disease developing. And it's extremely high right after they're infected. It may go quiescent for a little while, but it's still 2 to 3-fold higher or 5-fold higher than the HIV negative population. So my question is, why should people living with HIV at such high risk and high burden settings have to wait until they actually get TB to go onto ART? Because we're not really we're talking about, maybe the current guidelines, but we're not really focusing on TASP per se, and we're not focusing on the potential for test and treat. What might the potential for test and treat be as far as TB control goes? And I'm trying to look at this from a human rights perspective. PL-HIV have a right to access treatment that reduces their risk of getting or developing TB and of spreading it to others and potentially their own loved ones, just like they have a right to prevent spreading HIV to others. And the risks in these areas are not small. And unfortunately, current options such as IPT, isoniazid preventative therapy, don't go far enough. They're not effective enough. I think we're all cheerleaders for IPT, but it only really reduces the risk. I mean, I think it's safer to say it reduces the risk than it prevents TB. Even to people who are taking it consistently, it reduces the risk maybe by 30 to 60% at best. And that's not good enough. You have to realize, you have to remember that, people have a potential, possibly a 20 times greater risk of developing TB. In settings where the case rate is 1,000 per 100,000 or higher. It's not acceptable. It's not acceptable to have to live with that risk. Now, a cynic might say, if you looked at the clinical data, say that study in Haiti that showed that people who started ART before when their CD4 cells fell underneath 350, cut the risk of TB in half. And if you look at that study, people say, well, most of those TB events happened at 250 CD4 cells. But you have to remember that TB itself reduces CD4 cell counts. So when we look at these cohorts and we're seeing, okay, here's this big jump at 300, 250 CD4 cells, you have to remember that if you see a person who comes in with 250 CD4 cells and 350 CD4 cells, they very well may have had 550 CD4 cells the last time you saw them in your clinic. So the person who, but again, like I said, we still haven't really addressed the potential impact of TASP, or let's say the universal offer of ART to people who test HIV positive, which is what I prefer. And one thing I should probably add is that there are other knock-on effects of being HIV infected on the TB epidemic. Say, for example, with second-line drug resistance, multi-drug resistant TB epidemic, second-line drug resistance. It's been shown, there was a study in CID last year, Shova et al., that showed that being HIV infected was a major risk factor for developing resistance to key second-line TB drugs. So if we act upstream, if we improve people's health much before they get to that point, we could actually be having an impact. We could actually wind up having an impact on MDR-TB in sub-Saharan African settings, particularly countries like South Africa, where I live. We also don't know really what the effect of early treatment might be on susceptibility to primary TB infection. Now, the basic science around this is murky. We know that TB, obviously, that people living with HIV are at a much higher chance of developing active TB, but we don't really fully understand exactly why some people who are exposed to TB, when TB is ubiquitous, why some people who are exposed to TB don't develop latent TB. In the same household, half the people might be, with an active TB patient, half the people might become TB infected, and the other half not. So there are factors that we do know increase risk of TB, things like working in the mines and inhaling glass shards, and indoor house smoke and pollution. These things all do actually increase the risk of acquiring primary TB infection. So I think it's reasonably safe to assume that the inflammation that's often associated with HIV infection may actually boost risks of TB acquisition. But we need to do the basic research on this, and this is an area that I don't think is really being adequately looked at. Finally, despite the health system synergies that Hailey was pointing out, and there are, and we need to optimize them, I think it might actually be much safer to just sort of bypass it altogether. It's probably a much better, they always say prevention is better than cure, but much better to avoid getting TB in the first place. I mean, from a health system's perspective, it's just simpler. Why? I mean, Hailey and Samaya said it. People with TB don't get diagnosed soon enough. And many of them die, especially if they're living with HIV. They have twice the risk of dying. So many die before being diagnosed. And then there's the added effect of the people in their households that they may infect. Even if they're smear negative, there's a chance of onwards transmission. And also, as has been pointed out, healthcare workers are still, in many countries, very resistant to putting people living with HIV and TB on ART. It's still an uphill battle on that. Many doctors don't want to do it. And some countries are even producing data saying, we can wait until after the active or the intensive phase of TB treatment. So I think we'd be better off actually just avoiding that situation altogether. And we need to look at this. So we need to look at, in this higher bracket of people who are really just diagnosed, if they had access to ART, what might the consequences be? And I don't think the data that we have currently addresses that.
Thank you very much.